Okay, so this is a little bit younger gentleman, 57 years old, relapsed refractory diffuse large B-cell lymphoma, progresses after second-line therapy and including autologous transplant. Remember the CORAL data I showed previously, low response rate, less than 50%, median PFS of about 10 months in this population. This gentleman also has good social support, and he's motivated to pursue, quote, all options. So I've listed his treatment history here, September to December of 2021. He received 6 cycles of R-CHOP, entered CR1. He progressed about 2 years later, progressive disease on biopsy with recurrent CD20 positive diffuse large B-cell lymphoma, received 2 cycles of second-line rice, achieved a second remission, and went to autologous transplant. And the beam is the chemo conditioning that he got. About a year after transplant, he again has progressive disease. So very, like I said, outfits the definition of the CORAL population perfectly. And the question is, what do you do next for this gentleman? And if I can continue, I would just say that I think the T-cell redirecting therapy is where it's at here. I think he either needs a bispecific or a T-cell engager, or he needs CAR T-cell therapy. Of those 2 options, only you remember on my slide I said potential for cure, and I think that is, of those 2 options, CAR T right now is the only one that has that potential for cure. So I would lean heavily in that direction. If he wants to pursue all options, I would tell him that I think that's the best option available for him.
I have to say, Dr. Bird, that has to be a really good way to at least sort of kind of have the patient not necessarily convinced, but relay the importance of this therapy, right? You can actually tell them that they could be cured with CAR T, which a lot of us can't say in other diseases. So have you seen that? Like, is it easier to convince a patient like this with diffuse large cell versus someone with follicular lymphoma, for example, where you don't know yet? I'm curious. Does that play into it?
I mean, I think so. I think what we've had to train ourselves is, people only listen for a short period of time. They hear something and they stop hearing you. So, I mean, I've had to train myself, and I think we're learning that that's the first thing you say. Like, I have a potentially curative therapy for you, and try to get that in before they can't hear anymore. I think that's one of the first things that we lead with, is that we still have potentially curative therapies or potentially curative options in this setting, and they're safe, they're well tolerated, and let me tell you a little bit more about them.
So in this case, so this patient relapses after the first relapse, they went on to a transplant. Would they have been eligible for a CAR T at second line?
No, good question. Not in the second line setting. So right now, primary refractory is defined, presumably no, should be my answer. So in the second line setting, we can, the label is primary refractory, so relapse within 12 months of frontline care therapy or failure to achieve a CR. With the liso-cel label, which I don't think fits this gentleman because he got an autologous transplant, within the liso-cel label, you're able to offer liso-cel in the second line setting for people who are quote, transplant ineligible. So in that setting, he's young, and that's part of the reason why he's 57 years old, and his initial disease-free interval was over 2 years. But had this been a 78-year-old DLBCL, relapses 14 months afterwards, I think liso-cel would be an attractive option in that setting.
Right, and theoretically, so thank you for that explanation.
Yeah.
Theoretically, a patient that does not meet that primary refractory definition has a cure rate as well with transplant, which is why that remains the standard of care in that population. Correct.
That's correct.
So even though we don't have a head-to-head data, I'm assuming, I don't think, in the population, CAR T versus transplant.
You're correct. And what I would say, maybe, Dr. Beha, is, when we get rice, when this gentleman gets his rice chemo, nobody knows what what direction we're going to go in, right? So if he gets a response, if he achieves a CR with rice, we're going in the direction of transplant. He's got chemosensitive disease, and we're going in the direction of transplant. If he does not, if his scans don't show remission, if they don't show response, if they show stable disease, then this gentleman's path looks a little bit different. We'll start to talk about CAR T cells then. So his response to second-line therapy matters. I would say the disease-free interval is one step. The second step is how does he respond to second-line therapy? And I think that will dictate what path we go down.
Got it. So I'm curious how you manage that with the referring doc. If they're giving the rice, sort of kind of when that conversation comes in, is it at the time of the transplant evaluation? Can it be done sooner? How do you navigate that?
Yeah, it's a good question. I think you tend to know. I mean, you know how people are responding. You can tell by their LDH. A lot of these people have palpable disease. You know if it's getting better. You know if we're moving in the right direction. The people who are chemo refractory, I think we're pretty good at picking out early on, and those are the people that we tend to get out. Start to say we think you should meet with the transplant. The people who are responding, I think then we send them over to the transplant people.
Yeah. So I guess
and they can generally.
Sorry. So I guess if you were to recommend RISE for 2 cycles before going to transplant, but after 1 cycle the patient's clearly not responding, they probably should reach out, right, and say, hey, I don't think this is working, because it might change. It potentially would change the plan.
Correct. Absolutely.
Okay. Got it. I know next time. I won't give it that. So in terms of toxicities, just like with the follicular patient, any particular toxicities with this patient population compared to others? And this was sort of our standard, right? I guess ALL and diffuse large B-cell.
Well, yeah, I think we see a little bit more toxicity with the large cells than we do with follicular. There's some variables. I think many people recognize these. Disease volume of disease is a consideration here, as is the product. The different co-stimulatory domains, the different constructs, there are differences in the toxicity between the 2 products that we use. I guess 3 products in the third-line setting here. But what I would mention is that there's other ways there's other differences beyond toxicity. I mean, there's manufacturing differences, there's turnaround time. So all of those are sort of factored in when you're picking what is the best product for this gentleman. And the biology of his disease, how long he can wait, the risk of out of spec, as well as the toxicity profile all kind of factor in as we're selecting products.